इसमें बोलना है. Hello. So in the coming few minutes of journey, we will be going through the burden of diabetes distress in type 1 and type 2 diabetic patients, and what is the difference between major depressive disorder and the diabetes distress. Comprehensive approach will be done for screening and diagnosis of diabetes distress, and how the treatment approach should be there, we will see in the coming few minutes. What is euthymia? First we should know, then we can understand the distress. Eu means normal, well. So euthymia means well mental health, good mental health. So that is required in diabetic population also, because our patients are afraid of the disease. They are diagnosed, they are in the mode of depression, denial, or any various modes are there when the patient is diagnosed with diabetes. So to begin with, we will start with the burden of diabetes distress, and what is the understanding and the hurdles living with the patients who are living with diabetes. Diabetes is a disease which has a profound impact on both the physical and mental well-being of the affected individual. You know that diabetes related stress or distress, that is diabetes distress, DD, which I call, it leads to burden of self-care, interpersonal issues, emotional worries regarding the ability to cope with the illness. There are relationship with the caregivers and healthcare professionals which are very important part which we neglect. So diabetes distress is defined as opposite of euthymia. That is defined as an emotional response characterized by extreme apprehension, discomfort, or dejection due to perceived inability of the patient to cope the challenges to live with diabetes. So it is the extreme apprehension, discomfort, or dejection to live with the diabetes. So my dear friends, we know that prevalence of diabetes distress is very high, which we neglect in both type 2 and type 1 diabetic patients. It is about 36% in this study. The overall prevalence of DD was found, that is diabetes distress. And in type 1 diabetic population, the prevalence was 42.1% and 54.4% was incidence in type 1 diabetic population. The time points in diabetes patients' life, they are associated with increased level of diabetes distress in these stages. At the time of diagnosis, at the time of learning how to self-manage the diabetes, at the emergence of a complication, at the time of switching to the insulin or oral therapy, and even they are distressed at the time of switching over the doctors or healthcare givers. So diabetes distress is often confused with depression in our day-to-day clinic. So how you can differentiate the diabetes distress with the major depressive disorder? So major depressive disorder, we know, is a complex and debilitating condition which frequently coexists with diabetes. In many patients we see they are depressed, but diabetes distress is different than the major depressive disorder. In type 1 it is nearly about 12%, and in type 2 it is 19%. So patients with diabetes and major depressive disorder have ultimate poor health outcomes, and they have high mortality. So is diabetes depressed labeled as same as clinical depression? No, my dear friends, it is not the same. And unlike depression, the diabetes distress is a persistent over time, associated with glycemic control and disease management problems, and it is expressed in terms of magnitudes, that is severity, and content, that is nature of distress. So diabetes distress and depression can co-occur. However, it is important to differentiate them and treat them accordingly. So major differences between the MDD and DDR. The major depressive disorder should have at least 5 of the 9 well-defined symptoms that we will see, and that persist for at least 2 weeks, like not having the thrill in watching the TV, playing games, he is depressed, not eating properly or overeating. All these are some symptoms of depressive disorder. So based on patient symptoms considered as a comorbid psychiatric disorder. In contrast, sorry, the DD, that is diabetes distress, is defined by context of diabetes and its management, and includes a wide range of emotional experiences. It is based on source of diabetes distress. It is not considered as a separate condition, indicating psychopathology of the different forms of the spectrum of diabetes. So the depression, I have told you 5 out of more of the below mentioned symptoms should be present. That is depressed mood, diminished interest in the activities, change in appetite, change in sleep pattern, either he is sleeping more or less, psychomotor agitation or retardation, fatigue. All these are the symptoms of depression. In spite of that, the diabetes distress If the patient is unmotivated, burnt out, overwhelmed, frustrated, angry, he is feeling guilt, fear of hypoglycemia or complication, and he feels lonely. So these are the basic differentiating features between DD and MDD. So there are various diagnostic criteria for DD, that is problem areas in diabetes, PAID, diabetes distress scale, that is DDS. And for depression, we know that there is PHQ-9, Center for Epidemiological Studies Depression Scale, which is CSD. So measurement of depression and distress is important owing to high prevalence of comorbid disorders and persistence of depressive affect and diabetes distress over time. So you have to follow these scales or screening pattern. You can teach or make a multidisciplinary team in your clinic to diagnose this diabetes distress, to screen it, to counsel the patient. So screening and diagnosis is very important, but because you don't have time, you have to make a team in your clinic. So need for development of diabetes distress scale. There are various limitations in the measurement used for screening diabetes distress. There was 2-point scale which was used previously, which included feeling overwhelmed or feeling that I am often falling with my diabetes routine. It is not proper. Now the newer scale is 17 features scale. It is very cumbersome to do it in our clinics, but you can train staff that just ask these questions, and if it is not a problem, you give the score of 1. If it is a problem, it is a very serious problem, then it is 6. So out of these 17 parameters, you can ask the patient one by one, and patients are required to consider the degree or level to which each of the items included in the scale may have distressed him or her during the past 1 month, and then to circle the appropriate number. So basically, this is a multidisciplinary approach therapy, or for even diagnosis and treatment also. So 17 DDS score aids in identifying major sources of diabetes distress, that is powerlessness, negative social perceptions, friend or family distress, physician distress, hypoglycemia distress, management distress, and eating distress. So these are the various features which we should rule out, and these are the areas where we should screen the patient. The 3D study have highlighted that DDS 17 score have shown the key diabetes variables, that is the HbA1c, self-efficacy, healthy diet, and physical activity. So if the patient is having diabetes distress, A1c will go high, he will have less diet control, and physical activity will be less, and self-efficacy, self-management will be less. So if the diabetes distress is overtaking your life, so you will have bad control of diabetes, diet and exercise will be left behind. So coping skills assessment are usually primary investigation for DD prevention and treatment. There are 6 styles analyzed by glucocopper questionnaire: the negativity, acceptance, blame, optimization, planning, and action. All these you have to screen in your patients, that how the coping styles are there, and the management strategies are very important to improve the self-perception, to improve the coping skills, minimize the burden that needs to be coped with, involve other partners in coping. So my dear friends, in this, the family support is very important to overcome the diabetes distress. So it is a self-perceived insufficiency of coping skills, hence most management approaches need to be focused on the individual. So diabetes distress is very important to diagnose and to treat it. The self-care is very important to train the patient for self-care, for the healthy dietary habits, exercise habits, self-monitoring of glucose, and if he is on injectable therapy or oral therapy, they have to be taken care of their own. So self-care is very important. There is a AEIOU approach for the therapy, and that is ask and assess coping skills A, eliminate negative coping skills E, internalize positive coping mechanisms, observe ongoing basis, upgrade one's understanding. So AEIOU mechanism can be taken for therapy, and for minimizing discomfort of change, you require the breaking changes suggested to discrete bits, prioritizing action for change, focusing on essential parts, making complete use of human resource and technology. So methods to minimize discomfort of dealing with change caused by diabetes are simple. You have to train them in these areas. So targeted areas are diabetes-related emotional burden, physical stress, regime-related stress, or interpersonal distress. So multidisciplinary treatment approach, which I have told you, is specifically targeting the 4 areas of distress. They are very crucial for diabetes-related distress management. So multidisciplinary approach, which will take care of emotional burden, interpersonal distress, regime-related distress, and physician or healthcare-related distress. So these treatment approach team, you have to make it. So my dear friends, the clinical pulse, the alarm is belling. You have to diagnose these patients at early stage to prevent sudden fluctuation in A1C levels, to prevent the major life changes and emotional reaction of negative results. So, sorry, you have to diagnose this DD very early in the stage of diabetes patients, which we are missing. So to teach them how to cope with the distress, so listen to the patient properly, identify the underlying feelings can help manage distress properly, help patient to talk about the experience of having diabetes, identify the specific source of their distress, normalize these feelings, and help patient to cope with distress as a part of regular diabetes care. So to summarize, the key take-home messages are: diabetes distress refers to the emotional response encompassing the extreme apprehension and discomfort consequent to the perceived inability to cope with the challenges of living with diabetes. So our newly diagnosed patients are very much afraid that how I will live my life with the diabetes. So we have to teach them that you have to just follow the diet, exercise, and take the medicines properly so you can live the normal life. So diabetes distress has to be overcome by counseling and proper channelizing the patient to the various aspects of psychological therapy. Differentiation of diabetes distress from depression is very important because the treatment approaches are different, and identification of cause of distress and optimization of practical aspects of diabetes distress management contribute for overall health and well-being of the affected individual. So to finish with, my dear friends, we know that this is a very neglected part, that is diabetes distress, which we don't diagnose. So we need a multidisciplinary team in our clinics, as we have trained the diabetic foot, our paramedical staff for foot diagnosis. The problems of foot are to be screened. So we have to make a multidisciplinary approach in our clinics from today. If the patient is coming, you should say, or you can train the dietitians or your paramedical staff that you should inquire about those 17 questions and to diagnose the diabetes distress. And by psychotherapy or counseling, we can overcome the phobia that the patient is diagnosed with diabetes. So thanks a lot for your patient hearing.